welcome to a very special episode of Managing the Problems of Daily Living. I can't tell you how pleased I am to have a great mentor of mine, Dr. Joel Becker, here all the way from Beverly Hills, California, to speak to us about the evolution of CBT and how he sees the changes in the field from his perspective as, in his words, an older psychologist. We want to welcome you, Dr. Becker, and thank you so much for taking the time of what I know is a very busy schedule to join us today.
You are very welcome, Linda. And when I first heard your voice, I immediately was able to picture you. The voice is the same, and you look pretty much the same. And I think it was a good 40 years ago that we were knowing each other back in Boston. And it's a delight to talk with you today. And
you took a chance on me because I really, came from a very traditional program at Nova Southeastern where we learned it was a scientist practitioner model, but we really didn't have a lot of experience with clinical work or supervision. It was very much research-based. And I really learned how to be a psychologist from you. I was thinking about that before we spoke today. Dr. Azrin had his behavioral kind of modality and treatment protocol, but really you just had to kind of plug in and there wasn't a lot of wiggle room. But you really taught me how to approach the client and how to conceptualize the case and how to connect and everything that's important to being a working psychologist. So I really appreciate it.
Thank you.
So we wanted to start today to talk about, you have another thriving practice in Beverly Hills, California. I trained with you in Boston, Massachusetts, and the practice is called Cognitive Behavior Associates. So from the name, we can learn that your focus is cognitive behavior therapy.
Correct.
And why is that, Dr. Becker?
Well, let me talk a little bit about how I got here.
Okay, please.
So, I went to undergraduate school. I majored in psychology. I went to a small college named Hobart College in upstate New York. And then upon graduating, I applied to APA-approved clinical psych programs. And the one I got into, at that time they were very hard to get into. It was the end of the hippie era, and everybody wanted to be helpers. And so I got into the University of Georgia in Athens, Georgia, which was one of two schools that had adopted a radical behavioral approach. So this is 1971. Radical behavioral approach, and a new kind of therapy had been emerging since the middle 1960s called behavior therapy. So that program rejected all psychoanalytic thought. In fact, we never learned to do Rorschach testing because they said, why would we do that? We don't necessarily believe in projection. So a lot of those standard things were just not included in my program. It was very behavioral, lots of science, etc. And then I think because I was young and I really wanted to go to Boston, and to be honest, I wanted a Harvard affiliation on my vita. And so I applied to Massachusetts Mental Health Center in Boston, and I did a totally psychodynamic internship for really 1 year plus another year kind of as a postdoc. And I immersed myself in the psychodynamic world, and I had process supervision and all the kinds of things that people get in that way. By the end of the year, 2 years, I had had one case that was really seminal in my going back to behavior therapy. It was a child case, and it was at a local mental health center, and I had a really rigid child therapy supervisor who wanted me to do play therapy with this little boy who was refusing to use his right hand. And interestingly, his mother had a hook for a right hand. So the psychodynamic interpretation was that he had introjected his mother's disability, and that's what was going on. I was never allowed by this supervisor to talk about the problem itself. And around that same time, interestingly, B.F. Skinner was developing a program at Harvard for dysgraphia. Kids who were having trouble writing. It was a really cool notebook where they would write on sort of a vinyl sheet, and if they were on target, it would appear, and if they were off target, it wouldn't appear. So I knew there were behavioral ways to address this anxiety, this phobia, and it wasn't okay for me to do it. So at the end of that year, I sort of felt guilty and said, is this about allegiance to treatment models, or is it about helping people? So that sent me back into behavior therapy at the time. We're now in the middle 1970s, and something was missing in behavior therapy to me. Number one, I had done my master's thesis on an existential topic and had done work about Viktor Frankl and developed a test to measure a concept called responsible being. And I was pretty much, I often describe myself now as a cognitive behavior therapist with an existential humanistic philosophical orientation. That's a mouthful, but that's who I am. And so existential models have been always very important to me. You know, there is a form of therapy based on that that's called logotherapy / meaning therapy. Viktor Frankl's book, Man's Search for Meaning, he describes a therapeutic approach. I don't think anybody does logotherapy per se, but I think many of us have that it's imbued in us. It's part of what we do. So I don't counsel people toward happiness, I counsel people toward creating meaning in their life, and I think that a byproduct of that is that they're content. So moving along, all of a sudden in the middle to the end of 1970s, this new therapy emerges called cognitive therapy, first written back in 1976 by Aaron Beck. In 1979, he published his very famous book, Cognitive Therapy of Depression, where he showed it to be as effective as antidepressant medication, and that really put cognitive therapy on the map. I always knew that we were missing something in behavior therapy because I think of humans as a thinking animal. And in behavior therapy, that was a hypothetical construct that you stayed away from. Well, all of a sudden, looking at what people were thinking or not became legitimate subjects for the scientific study of human behavior. Now, throughout the 80s and the 80s and up to the 90s, cognitive therapy became combined with behavior therapy. So I say what was once an oxymoron, cognitive and behavioral, became two words that are inextricably joined. And Aaron Beck, interestingly, in '79, drops his objection to behavior therapy, which he had in his first book, but by the second book, he has become essentially a member of our organization, the association, at that time it was called the Association for the Advancement of Behavior Therapy. We've changed that name now to the Association of Cognitive Behavioral Therapists. So you can see how much Beck has integrated his model into our model. There's no such thing as a cognitive therapist who's not also a behavior therapist, and vice versa. In the 1990s, things started to shift even more. So we call behavior therapy the first wave. We call cognitive therapy the second wave. And the third wave of CBTs have all been CBTs that are based on acceptance models. A lot of people like Marsha Linehan developing something called dialectical behavior therapy, where you're balancing acceptance and change. And there are things that we have to accept in order to be in a place to change it, or we just have to accept certain things. And all of a sudden, meditation was being taught as part of cognitive behavior therapy. It's now called mindfulness-based cognitive therapy. And I remember going to my first workshop at ABCT on mindfulness-based treatment for generalized anxiety disorder, presented by two brilliant researchers. And when they started with this exercise of closing our eyes and seeing clouds going across the sky or whatever we were doing to bring us into the moment at that exercise, I had a thought, what would Dr. Skinner, if he was sitting on my right, and what would Dr. Wolpe, if he was sitting on my left, be saying about this? I thought of it as very new agey. And, you know, both of them gave me an answer. They both said, if there's data to support it, we're behind it. And the data has accumulated tremendously for the application of mindfulness-based approaches in cognitive behavior therapy. In addition, in the third wave, we have other therapies that look at acceptance. So we have things that are called compassion-focused cognitive behavior therapy. And that comes from a finding that people who are more self-compassionate change better than people who are self-critical. So helping patients to move to a more compassionate self has been a very helpful, I don't call it a new therapy, I think of it as a wrinkle. It's a wrinkle in how we do CBT. And there have been so many new changes in the last 20 years. And that's one of the things I find particularly exciting about being a CBTer, is if you went to our annual convention, there's always research studies on a new way to do something, a whole new way of looking at something. And if anything, cognitive behavior therapy is the most flexible, not static form of therapy. We incorporate into therapy what the research has shown to work. And I found that to be really fitting with what I wanted to do, which is I'm there not to bring alliance or allegiance to cognitive behavior therapy. And by the way, the head of psychiatry at Cedars-Sinai here, who was very psychoanalytic, used to refer to me and say, I like to use you, Becker, for CBT because I know you're informed from a psychodynamic perspective. My thought was, I'll take the referrals any way you want to give them. Interesting, we had both been at Mass Mental in our history.
Oh.
Yeah, and so we have a number of psychiatrists out here who were trained there. So they trust me because I've had this psychodynamic training.
You speak their language. You can't speak their language.
Yeah, way back in 1980, I was invited to teach at one of the analytic institutes in Boston, behavior therapy. And that was because they wanted to know, quote unquote, what was going on in the enemy camp. But I don't really think they thought of it as the enemy camp, or they wouldn't have invited me. They just wanted to know. And that was a good introduction to being flexible, realizing that everybody has a viewpoint that there's got to be something helpful in.
How do you respond, and then we need to go to break, how do you respond to people that hold on to these modalities that appear to be, if not outdated, but not validated by the behavioral outcome literature, like the analysts who continue with talk therapy when there are these, they're not so new agey, right? CBT or exposure therapy, we know to work for specific problem areas.
Exactly. How do I react? So I could give you my politically correct answer, which is everybody's invited to the table. And then I could give you my more critical answer, and it is embodied by, I was asked to be on a panel for an organization called SEPI, the Society for the Exploration of Psychotherapy Integration. They had 3 people record a 10-minute session, 10 minutes of a session, and then we discussed it. There was a neo-analyst, there was me, and there was a traditional analyst. When they asked the traditional analyst why he was doing what he was doing in relation to the patient had performance anxiety and was a musician, he told us it was an irrelevant question. So I was sitting next to a very famous person in CBT at the time named Jerry Davison, and Jerry whispered in my ears, this is the kind of response that gives psychologists a bad name. Why you would not be interested in how the intervention is related to the client's presenting problem is you're more interested in the intervention than you are in the client's problem. The client was free associating to, I think, the analyst's wallpaper. None of us in the room could understand how that was going to help this client with his performance anxiety. And, I've been accused of being pre-operational in my thinking. I'm pretty concrete when it comes to wanting to help people.
I think you look to the literature to see what works, right?
Exactly.
And as we said before the break, that you stay current, and you've got all these people at high-level training, and that's your job to make sure that they have the most current information available. Dr. Becker, we will return in a moment to continue our conversation about not only the evolution of CBT, but also how you are adapting and changing with all of your many years of experience. And we will be back.
Okay. Thank you.
This year, patriotism shouldn't just be about pride of country. It should be about love. Remember that to love America is to love all Americans, because love has no labels.
Welcome back to a very special episode for me, and I'm guessing for you as well, of Managing the Problems of Daily Living. I'm honored to have a great mentor of mine, Dr. Joel Becker, on to discuss not only the history of CBT, but its evolution and what he sees in terms of his work in the field as the important changes that have happened, including his embrace of mindfulness and its effect on not only himself, but his clients. So welcome back, Dr. Becker.
Thank you.
I just wanted to mention before we started our conversation about the specifics of generalized anxiety and how you see the evolution of CBT working within that framework. A colleague of ours mentioned that you had been a childhood actor and you felt that the impact of that experience resonated for you with clients.
I definitely think so. And I think that there is, first of all, people think of CBT as one animal. It's not. There's dozens of forms of CBT today. One of the other major forms of cognitive therapy beside Aaron Beck's form is a form called rational emotive behavior therapy that was associated with somebody named Albert Ellis. And, people joke about Ellis, and he was not for everybody. He was quite a character. He passed away just a couple of years ago at 92. I saw one of his last presentations here. And he believed that the therapy, so it stands for REBT, Rational Emotive Behavior Therapy. The emotive piece is both for the therapist and for the patient. So asking the patient to say something with more feeling, having the therapist do something that elicits a feeling. He has a famous intervention where if a patient keeps bringing up the same automatic thought many times that you've disputed, he'll take a book in his hand and he drops it to the floor and says, "That goddamn thought again?" His approach wouldn't be for everybody to do. I have a little New Yorker in me, as he did. He was a major New Yorker. And I can kind of get away with it. I can even do a Brooklyn accent, to imitate him. And so I think the emotional piece probably comes from some of my acting training. Yeah.
And I think patients connect, right? I mean, and if the person wasn't for you, what you taught me in practice is there are lots of therapists and it's a customer-based business.
Right. That's an interesting thing about what's important to me. I wrote my doctoral thesis on the customer approach to patienthood based on something that was developed by Aaron Lazar at Mass General Hospital. They later changed it to the negotiated approach to patienthood because they found the word customer too crass. I actually like the word customer. I think we must treat our intakes, our new people, as not only patients, clients, but also as customers. So in general, there's very little mystification in CBT. I love that. When people ask me, well, how is this supposed to work? I don't reflect and say, well, how do you think it's supposed to work? I tell them how I think it's supposed to work. So it's very consumer-based. It goes with what you just said. If I don't feel like there's a good connection by session 3 or 4, I'm going to talk about that with them and see where we need to go. So, one of the ways in which I think I can talk about my development, the field's development, and talk about a little bit of intervention is to talk about the treatment of generalized anxiety disorder as it has changed and developed over the years. So when I first started and I was a behavior therapist, we would have seen the problem as reducing anxiety. And we had a number of strategies for reducing anxiety, like relaxation techniques. We looked at activities that would result in anxiety reduction. I think it's when we first started doing exercise as a psychological behavioral intervention. So that was around for a while, and then the results were interesting. In the other anxiety disorders, we were getting really, really high results. But in GAD, where the hallmark of the diagnosis is excessive worry, it was lagging behind. In other words, we were up to 85% with phobias and 90% with panic, and OCD was getting well treated already. But GAD was lagging behind at about 65 or 70%. And then someone decided to add something called mindfulness-based cognitive therapy to it. And Well, first we added cognitive therapy. I skipped one major part. Cognitive therapy was, of course, based on Dr. Beck's work of looking at what people were saying to themselves. The schema for anxiety disorders is that people are always assessing the risk over their resources ratio. And when they perceive risk as greater than their resources, they're going to have an increase in their anxiety. Well, in both parts of that equation, there are rooms for lots of cognitive errors. So we clean up the cognitive errors. Also, we pump things into the bottom of the resource of the equation. So for example, if you're coming for me and you're afraid of going swimming, I'm going to get you swimming lessons. If you have social anxiety disorder, I'm going to make sure you've read some books on conversationally speaking is one that I use, for example. Because the worst thing a therapist could do is talk a patient out of their anxiety about a social situation without checking out their skills. Because
Right.
then you send them out to an in vivo experience and they fail. Okay, so the cognitive therapy addition and cognitive therapy after depression in the 80s and 90s became applied to virtually every psychiatric diagnosis, including psychosis today. So we have a CBT-P model for psychosis. So the cognitive therapy model definitely increased, but again, we were lagging behind. And then we get to around 1990, and we hear about this thing called mindfulness-based cognitive therapy. Another mindfulness-based approach, or third wave, was acceptance and commitment therapy. And what happened in that third wave was the balancing between acceptance and change. And so all of a sudden, I found myself teaching my clients meditation practice. Why? Because in the mindfulness-based conceptualization of anxiety, you can be in three places in time, Linda. You can be in the present, you can be in the past, or you can be in the future. And what do you think, where are people who are depressed? They are generally in the past, and they're saying, I should have, I could have, why didn't I? And people who are in the future are generally anxious, and they're saying, what if, what if, what if? Well, as my mentor in that arena, John Kabat-Zinn, says, the past is a history that you write and rewrite based on what's happening in the present. And I think all of us have seen that. Patient starts out at the beginning of therapy talking about something one way, 4 months in, they've changed the story because it's something in the present has resulted in them needing to change the story. And then, so he calls that a history that we write and rewrite. When you're in the future, he calls it science fiction. And they did an interesting study on people with GAD. I think it was about a 3-year study where they looked at the things that people with GAD were worrying about. Guess what? 95% of those things never happened. And the 5% of things that happened that were bad were things that people never even thought of. So how many of you were worrying about a pandemic last October? Almost no one. And so the thrust of the third wave therapies is to help people to be in the present, to help people to accept and change, and that increased our success rate to 90% from 70%. So now I spend a lot of my time dealing with acceptance. I love some of the interventions from Steve Hayes, where he helps us with acceptance and balancing it with change. The compassion-focused approach is very much a context within which I like to work, which is we found that patients who are more in a place of acceptance about their problem versus being self-critical then change more easily. So take two guys just had a 12-year relationship end. The person broke up with them. One guy says to me, I don't know why I'm here. I should be able to deal with this. It's not the end of the world. Please help me be less depressed, Dr. Becker. The second patient says, I guess most people would be pretty down after a 12-year relationship ends, and I don't really know how to get out of here. I haven't been here before. Can you help me, Dr. Becker? Who's easier to help, Linda? The second person. So helping people to develop a more compassionate stance to themselves, to learn about what I'm reflective of the Serenity Prayer in the program, helping people to figure out what they can change, what they can't change, and do something about what they can change, and learn to let go or accept the other.
I've actually quoted that line myself with people. So I think as we move to close, and this hour is gone, this time has gone very quickly, I think that we can see evidence with the new research, but also your own experiences in kind of adding, I don't know so much about deleting to CBT.
Yeah,
I don't even want to say the traditional therapies. Go ahead.
Yeah, I think that I have not deleted traditional cognitive therapy. I have not deleted behavior therapy. All of my trainees better know about principles of increasing and decreasing of behavior, because to me, that's a basic. And I'll just use a personal anecdote here, which is, you know, I used to sit and watch the evening news, and if you ever watch the national news, there's one ad after another about what people my age are going to get, you know, for medicines. And I would sit there and go, oh, am I going to have a stroke? Am I going to get this? Am I going to get that? And then I would say to myself, why are you going there, Joel? You're 60-something and you're totally healthy right now. And the simple answer was, Linda, because I didn't know how not to. And mindfulness taught me to know when I'm in the future. It's not mind control. It's knowing where your mind is. That's why the word is mindfulness, not thought stopping or thought control. It's mindfulness. To the extent that you can be mindful, here I am in the future, it does allow you to say, maybe I could start to count my breaths a few times and just get back here in the present for a minute. And that totally changed. So if I have a diagnosis, it would be GAD. I joke, I'm Jewish, we worry. And so MBCT has really worked for me, because in cognitive therapy, sometimes I could talk back to the talkbacks. And in mindfulness, it's simple. It's based on some really good science. And I would say both personally and with clients I work with, it works.
I absolutely agree. You see the results. Dr. Becker, it's been a delight to have you today. I want to thank you again. I know how busy you are. You have an appointment at the UCLA School of Medicine. I know that.
No, actually, I'm sorry. I'm no longer at the School of Medicine. My appointment is at UCLA Department of Psychology.
Thank you. You had said that. Thank you for the correction. And we so appreciate you being here with your experience, your expertise, and your compassion for the profession. Thank you so
Linda.
much.
It's been a delight to see you again.